Okay. And then just let me know if you can see my slides.
Yeah, I can see them.
All right, you guys can see them?
Mm-hmm.
Okay, yeah. All right.
All right.
Well, we'll let you go ahead and get started, and I'll let you introduce yourself, and you can tell us a little bit about yourself too.
Yeah, sure. So, first of all, thank you guys for participating in this. I think it's so valuable to be able to share information on a platform like this. As a, my name's Yifei. I'm a nursery resident at University Hospital's Cleveland Medical Center. And
hey, Yifei, just talk a little louder. I'm sorry.
Oh yeah. I'm a resident at UH in Cleveland, and I'm finishing up my 2 years of endovascular fellowship. And the reason I went into neurosurgery is because of an interest in cerebrovascular pathology. I think the anatomy is very intricate. The surgeries are very technically rewarding when done correctly, and the patients are very gratifying to take care of. And one of the passions of mine, and I think it's a topic that's not really discussed a whole lot, at least not in med school. Even in residency, a lot of this is kind of glossed over. But there's a diagnosis called a dural arteriovenous fistula. And I think to a lot of people in medicine, even to neurosurgery residents, it's kind of a black box. They can be very difficult to diagnose. They can be very difficult to correctly manage. And I kind of just wanted to highlight a little bit about my experience with dural arteriovenous fistulas during residency, and certainly over the past couple of years during fellowship. It's definitely changed my understanding of these lesions and how I approach them. And if at any time, I think this is very informal, at least I'd prefer it that way. You guys can chime in and ask any questions you guys want at any given time. But we can go to the first slide here. So I don't have any disclosures. We can go to the next slide. So this is a picture that I wanted to include in the beginning of this presentation because when I first started as a resident, and I know for a fact that a lot of junior residents see fistulas like this early on. When they're first asked to go up, and during our cerebrovascular conferences, it's kind of comical. They're asked to go up and point out the anatomy. And when it comes to unscrambling a dural AV fistula, and you're kind of viewing at it with an untrained eye, this is basically what you see. You just see a bunch of lines. Oftentimes these angiograms just look like a complete mess. There's blood vessels everywhere, and it's really hard to make sense of what's going on. But I think over time, and I think after this presentation, hopefully, it'll be a little bit more clear as to what these things are and how really to, at least conceptually, treat them and take care of them. So we can go on to the next slide. So these fistulas, they're rare out of all vascular malformations. There's a broad category of vascular malformations. These include cavernous malformations, venous malformations, and arteriovenous malformations. Fistulas account for less than 10% of all of those. So it's a relatively small subset of an already rare diagnosis. The true incidence is unknown, but it's likely less than half per 100,000 adults per year. And by definition, the AV fistula, the dural AV fistula, are abnormal connections between arteries and veins located within leaflets of the dura. When I first started as a med student, this concept made absolutely no sense to me because I always thought, the dura is just a single layer of tissue. How could there be blood vessels within it? But if you actually think about it, all the dural vessels are just blood compartments within 2 layers of dura. And any abnormality in that can create a pathology like this called a shunt. They're typically thought to be acquired lesions, either secondary to thrombosis, trauma, tumors can be associated with these. And sometimes actually, as a result of cranial surgery, these can be acquired iatrogenically over time. But in reality, no one really knows why these happen. The clinical signs and symptoms are very diverse, and they happen because of high flow through the fistula system or due to venous hypertension. So normal venous outflow, either of the brain or the spinal cord, gets compromised, and symptoms manifest as a result. The angioarchitecture can range from simple 1 to 2 vessel connections if you're very lucky, but very often they're much more complex, and it takes quite a while to really study the anatomy to be able to come up with a management plan that makes sense. And the natural history of these lesions depends entirely on the venous drainage pattern. And I have some diagrams to kind of explain that a little bit more tangibly. They're complex lesions. They oftentimes involve multimodality treatment. Unfortunately, there's no medication that you can take to make these go away, at least not that we know of. So medical management is oftentimes out the window. So that really leaves us with some sort of intervention, either endovascular or open microsurgical treatment of these lesions. Not everyone needs to be treated, though, and that's something I wanted to kind of explain here in the upcoming slides as well. But they're very satisfying to treat because oftentimes the patient who presents with something like this are completely healthy otherwise. They often present in the 5th to 7th decades of life in adults. And the most common presentation is either someone who is completely healthy and then for the past 6 months has had this pulsatile tinnitus or this ringing in their ear, or they've had problems with myelopathy or hyperreflexia. They're clumsy with their hands. Some very kind of somewhat vague, but definitely neurologic symptoms in an otherwise completely healthy person. And once you've deciphered the fistula and treated it properly, a lot of these symptoms are completely reversible, which is why it's such a gratifying pathology to take care of. They do happen in children and neonates, but they're very rare. And when they do happen in kids, these pathologies are very complicated. They can happen anywhere throughout the dural lining of the brain, but the most common location, as you can see from this picture, is the transverse sigmoid sinus. The fistulas in that location produce the classic tinnitus symptoms because the fistulization is happening in the area behind the ear, and that noise, that pulsation actually conducts through the petrous bone, and that's why people have these symptoms that they do. But other locations can be the petrosal region, anterolateral to the brainstem. CCF is the carotid cavernous fistula, the cavernous sinus. That area can produce a wide variety of ophthalmologic symptoms. The superior sinus ones are very treacherous to treat, and the ethmoidal ones can cause historically frontal symptoms. So you guys may have seen patients who have had frontal lobe strokes, and the venous hypertension that these fistulas generate can actually also be accompanied with some of those symptoms. So we can go to the next slide. So I think this is a little bit beyond the context of this talk. This is kind of getting into the nitty-gritty details of the classification systems. I'm personally not a big fan of classification systems in medicine. I think they're just a way for people to get their names into the literature, to be honest with you. But the general gist of all these three systems, classification systems, is in my view, or in my mind, fistulas are either high risk or low risk. And depending on their venous drainage pattern, that dictates everything. And typically where most interventionalists will cut off high risk versus low risk threshold is the presence or absence of what's called cortical venous reflux. And what that means is venous drainage, normal venous drainage occurring through cerebral veins on the surface of the brain is compromised because blood is actually flowing backwards from the sinus system into these cortical veins. And usually when that happens, natural history studies have shown that that's typically indicative of someone who's going to have a really bad natural history. And I think the next slide kind of highlights where the cutoffs are. But these are thought to be, some people think that this is kind of like a natural progression of the lesion, that some lesions start off as a type 1, and then they gradually progress into this horrible looking type 4 lesion. Type 4 is a very high risk lesion where the arterial to venous connection ends up becoming directly, the artery directly dumps into the cortical vein. And not only does it directly dump into the cortical vein, but it also causes the vein to become ectatic or abnormally dilated. And as you can imagine, a normal vein is not equipped to handle arterial pressure, and that leads to direct brain compression. It can lead to hemorrhage risk. It can lead to seizure risk, all of the above. But these pictures are...
Sorry to interrupt you really quick. So if you have a patient that just presents maybe with like a type 1, could that progress into like the type 4, and like how quickly would you like rescan them if it does that?
Right. So that's a really good question, because a lot of people, I think, mistakenly believe that type 1, because they're classified as quote unquote benign, that they don't really need to be followed. But I have a couple slides coming up, I think, where it describes that these type 1 lesions, about 2% of them go on to progress to become higher risk systems. And I kind of dumbed it down to this diagram. I like thinking about things very simply. And I think this is even more clear than pictures. But the fistula system is basically a multitude of feeding arteries. Usually there's one or two dominant ones, which is why I have like one of these larger feeding arteries going into this fistula pouch. And the fistula pouch is just this abnormal interdural compartment. So it's an abnormal space between two leaflets of dura that then directly dumps into a venous system. And then when we're talking about the transverse sigmoid sinus system, it's usually a middle meningeal artery feeding directly into a fistulous pouch, which then dumps into the venous sinuses of the brain. So those past two slides are kind of the conceptually talking about how to seal these off. You can either seal them off from the artery side or from the vein side endovascularly. But if the endovascular approach doesn't work, then I put a little picture there of a microsurgical clip. That's usually kind of the end of the line treatment. But these are two studies that describe the natural history of these lesions. Again, they're very rare. So I think the true natural history of a dural AV fistula is still not completely understood. But I think these two papers are the best information we have in the literature about how arteriovenous fistulas behave over time. And what these two papers described was the benign fistulas, the ones that don't have cortical venous reflux, even they have a small chance of progressing to higher risk lesions. So I don't think it's enough to be able to diagnose this and just tell someone, hey, you have this benign fistula, nothing needs to be done anymore. They absolutely, in my opinion, need to be followed. And oftentimes they're followed with MRAs. MRAs are very sensitive to changes in flow. And if there's any change from year to year on an MRA, that would warrant another angiogram to look for higher risk features. When they do have cortical venous reflux, the natural history is pretty bad. NHND is non-hemorrhagic neurologic deficit. When someone has cortical venous drainage, the incidence of that happening is up to 6% per year. And hemorrhage rates as a result of this venous congestion can be up to 9.1% per year. And to put that into context, that's significantly orders of magnitude more risky than a diagnosis of a AVM or a cerebral aneurysm. Those rupture rates are typically in the for an AVM, the rupture rate is typically 2 to 4%, and for a cerebral aneurysm, it's about 1 to 2% per year. This is five, at least 5 times more risky than those types of pathologies. So again, this is just highlighting the fact that it's really a binary classification. You can parse this out into however many names you'd want in terms of a classification scheme, but it really just divvies it up into whether or not you have cortical venous reflux. And when you have cortical venous reflux, it ought to be treated. These are, again, highlighting the 3 different treatment modalities. I think the one exception for a type 1 or a quote unquote low risk lesion being offered treatment is if someone is so debilitated by the tinnitus, they can't go to work, they can't sleep at night because all they hear is ringing, and it affects their daily function so much that if you were able to get rid of the tinnitus, someone could go back to functional work. That would be a reason to offer treatment for a low risk lesion without cortical venous reflux. So the rest of the presentation is just some cases that I've had a chance to be a part of. For some reason in Cleveland, the incidence of fistulas is very high, at least the ones who present to UH. So it's good and a bad thing, but there's a wide variety of presentations that we've seen. Even in just the past 2 years during my endovascular training, I've encountered a lot of these. This first case is a 10-year-old girl who was initially referred for an MRI because she had an enlarging head circumference. And everyone before this MRI was thinking, oh, this is definitely hydrocephalus. It's got to be some obstructive pathology. So she went ahead and got her MRI, which you can go to the next slide, Kelly. And this is an MRI on the sagittal and axial sequences. You can see this abnormally dilated midline structure. And these are T2 and T1 sequences that show hypointensity surrounding the superior sagittal sinus. And whenever you see that type of appearance on an MRI, it just screams vascular. And for her, this MRI was demonstrating that there's this vast network of abnormal vessels surrounding the superior sagittal sinus. And you can go to the next slide. So she underwent a diagnostic angiogram, and these are pictures from her first diagnostic angiogram she had. The top 2 pictures are lateral projections, and the bottom 2 are PA projections. And what you can see, and I'll refer to the bottom left picture, that I don't know if you're able to give me a cursor, but that big thing towards the left, that big lateral swinging vessel that goes all the way around the outside, that's actually the superficial temporal artery. Normally, that's a normal vessel that just supplies blood to the scalp. But in this case, you can see that it's dumping into the superior sagittal sinus, and that wispy looking structure in the midline, that's actually the superior sagittal sinus lighting up early. I always think of angiograms as a 4-dimensional study, meaning that unfortunately I don't have videos of this, but an angiogram shows you what things look like over time. You're doing the injection and you're looking at the arterial phase, you're looking at the venous phase. And whenever you see veins at the same time that you're seeing arteries, that is by definition abnormal. And that's what's called early venous drainage. And you can see that these vessels are going into the superior sagittal sinus, dumping in and causing this fistulous or abnormal arteriovenous connection. So she underwent multiple rounds of endovascular treatment. This is a more dramatic picture of how ugly these things look. This is a 10-year-old child who has pretty bad vascular pathology. And thankfully, with a combination of endovascular and microsurgical approaches, this was treated. We use, in this case, a embolic material called onyx. and that is a trade name for a polymer called ethylene vinyl alcohol. It almost looks like a latex-like glue-like material. It seals up blood vessels and it finds these abnormal channels, and we take advantage of that property to seal up some of these abnormal connections. But despite multiple rounds of onyx, she still had some evidence of early venous drainage. So she was ultimately taken to the OR for microsurgical coagulation and clipping, and she ended up doing very well. Unfortunately, one of the side effects of all of this radiation is she was at very high risk for developing radiation-induced meningioma, and over time, she actually did develop a small convexity meningioma that was also resected microsurgically. But that's something to be especially mindful in the pediatric population. Obviously, in her case, there really wasn't a good alternative. You have to be able to see what you're doing. There's no way of shortcutting the radiation exposure for her, but she ultimately ended up doing very well. And this is just the name of the stuff that we use for the case.
Yifei, how was she like neurologically, like prior to the procedures and after? Or
yeah, so prior to the procedure, she was having headaches, and she was actually having ambulatory difficulties. She was stumbling on her feet, wasn't really walking correctly, and all those we thought were manifestations of cortical venous reflux. So her normal cerebral cortex wasn't draining adequately, and it was causing venous congestion. And I think if left alone over time, she would have been at high risk for hemorrhage.
Wow. So it looked like in the first slide, it said that at 21 months, that's when she had her first imaging. Is that true?
Yeah. So she had her first MRI at 21 months, and then she was sequentially multi-staged embolized. And, you can only embolize as much as the radiation limit and the contrast limit allows you to do. So unfortunately for a lot of these kids, you have to stage the treatment. So she was treated at multiple different time points. Ultimately ended up getting surgery when she was like 8 years old.
Wow.
But she's doing well with a long-term follow-up. This next case is a gentleman I had a chance to treat last year. He is probably the most classic presentation of a fistula, or one of the more classic presentations of a fistula. He's completely healthy. But over 4 weeks prior to presenting, he developed this horrible right eye ptosis and proptosis, and he was seeing double. His right eye was injected. It looked like someone, he got into a bar fight and presented to the ED as a trauma case, but in actuality, this is all atraumatic. So he underwent a radiographic workup. And you can see on the left, that is a what's called a time of flight MRA. So the way those MRs work, it specifically times the sequence to only identify arteries or arterial velocity blood flow. And you can see there on the right eye, there's this abnormal line lighting up. That's actually a structure called the superior ophthalmic vein. And normally you shouldn't see that on an MRA. It's a vein. It shouldn't have arterial flow. And you can use the contralateral side as a reference. The contralateral side is completely dark. So that automatically is a red flag that this guy likely has what's called a carotid cavernous fistula, which is exactly what he ended up having. So the pictures to the right are pictures of his angiogram. One is the internal carotid artery that we injected, and one is the external carotid artery that we injected. And you can see in the bottom middle of the screen, that little oval area, that area is actually the cavernous sinus. That's the cavernous sinus that you should normally not be seeing in the arterial phase. And again, you know that this is arterial phase because you can see the arteries. You can see the anterior cerebral artery, you can see the middle cerebral artery, and you should not be seeing veins during this part of the angiogram. You should be seeing veins a few seconds later. And that's early venous drainage. That cavernous sinus directly connects to the superior ophthalmic vein, which is that straight line going laterally up front to the eye. And it's basically causing venous congestion of his eye, of his right orbit. And you can even tell on the MRI to the left that that right orbit, that right globe is much more forward than the left orb. The eyeball itself is more protruded than the left eye. And clinically, it's very dramatic. You know, these guys look very uncomfortable. It's very disfiguring, and thankfully, there is an endovascular way to treat these. So we ended up doing initially a transvenous approach. We went through the femoral vein and threaded up a catheter all the way up to where that cavernous sinus is, and those that dark material on the left, those are actually aneurysm coils that we just put in the vein and gradually closed it down. This was a case where we actually initially got a incomplete treatment. We put coils in, and then the coils weren't really, at the end of the procedure, didn't really go in the area that we wanted them to. So we pulled the catheter back, and we wanted to reinforce the coil embolization with glue. So we glued off the back part of this fistula, but it was still filling. The right side shows that it's still filling just a faint amount. And you can see that compared to what this thing looked like initially, that looks relatively good. You know, it's not as nearly as ugly as it used to be. So, you know, we couldn't get really access into that area anymore. So we stopped the procedure. We thought we did a good enough job. But he ended up coming back about 2 weeks later with the exact same symptoms. And this just goes to show you that if you don't completely treat a fistula, it's almost like you didn't do anything at all. You either treat it all or you don't. Because if you treat it only halfway, not only do you eliminate a lot of your way of getting into the fistula, but the fistula also, for some reason, recruits more blood supply and creates the same symptoms and pathology that the patient had to begin with. So we staged them for a second embolization, and luckily we were actually able to get into that tiny little blood vessel that was still feeding it. So this is a slide that shows that we were able to get into the distal part of the right internal maxillary artery, put that same glue-like material called onyx in, and you can see the picture on the right shows all the embolic material. That's just a native x-ray showing the glue cast, the coils, and the onyx cast, and this thing completely shut down. His eye, by the end of the case, almost looked normal. So it's a very dramatic clinical outcome, and at 2-week follow-up, he was completely normal. His eye had looked symmetric at that point. So very rewarding, but sometimes frustrating case to take care of. You know, these cases take several hours of radiation and a lot of contrast. So definitely is not an easy treatment, but very gratifying at the end of it.
I can't imagine him having like that eye protruding. Now, did he like seek treatment pretty quickly when it happened, or like was this something that kind of started progressing over time?
You know, this was during the tail end of COVID, and he had just kind of dealt with it for 3 weeks. He thought initially it was like a sinus infection, and then he thought he had conjunctivitis. And then his wife told him, "Hey, like this doesn't really look right. You're definitely starting to look asymmetric." And he saw himself in the mirror finally, and he realized, yeah, he needed to come to the ED. So he came into the ED problem. I have a few more cases we can go through. Do you guys have any questions at this point? I'm happy to answer anything as we go along.
And Yifei, if I'm pointing somewhere incorrectly, just correct me or whatnot with your pictures.
Oh, yeah. All right. This lady, I remember her very well. She's one of the nicest patients I've ever met in my life. She's 60 years old, and just like the previous gentleman, completely healthy otherwise, but she had come in for evaluation for left-sided face and hemi-body numbness. And she was initially kind of presented as a TIA stroke patient, but we got an MRI on her, and we're very surprised. You guys can see that MRI is very ugly. It's a contrasted MRI, and that big, all those dilated vessels and that huge pocket in the middle, basically where the right half of the midbrain is, that's all dilated basal veins. And this just gives you an idea of how terrible the venous ectasia and venous extension can get, distension can get when someone has a fistula like this. And you can see on the angiogram that is starting to look like some of those abstract expressionist paintings that I talked about in the beginning. It's really hard to figure out what the hell is going on with these. And it really takes just looking at this frame by frame, and this single picture doesn't do it justice. You take these frame by frame and you look at the venous phase and it just looks terrible. And this ended up being what's called a petrosal fistula. And we tried embolizing this thing. That vessel that looks kind of like a sickle, these are both lateral projections, but that vessel that looks like a sickle, it goes forward and then it comes all the way back. It's got two little balls on it at the end. That's the middle meningeal artery. And to give you a sense of how abnormally dilated that is, the normal caliber of that thing should be that whisper that you see going straight up vertically. So that the caliber of that vessel is completely different than what it normally is. And that big pocket in the middle is a abnormally dilated petrosal vein, which is a normal vein of the brain, but it shouldn't be that big. It normally drains the lateral part of the pons and the midbrain into the torcula or vena galen and ultimately back up to the torcula. So that's a normal venous pathway that's just being hijacked by this abnormal fistula. And that's why she was having these symptoms, partly because of the venous congestion, partly because that dilated venous pocket was literally just smashing her midbrain and causing her symptoms. So we did a partial embolization. You can see that's kind of the before and after. On that last slide, we used liquid embolic. We used that onyx material again, but onyx is not always 100% easy to control. Sometimes the glue goes in places that you don't want it to go, and at a certain point, you kind of have to stop the procedure, otherwise you glue your catheter in there. So you can see that that big sickle is just a huge glue cast that we spent basically all morning developing. Some of the stuff at the bottom is glue or onyx liquid embolic in the occipital artery. And then you can see that titanium plate and that metal clip ended up being what she needed to treat this thing. She ended up having to undergo microsurgical clipping, a retrosigmoid craniotomy. And all it took, it literally just took a small metal clip on that petrosal vein to close this thing down. You can see the picture on the right is the after treatment, and all of that has been sealed away. That's a normal blood vessel at that point. And we actually did a follow-up angiogram on her about a month and a half ago, and it's amazing. Her veins look completely normal. And it's just absolutely, I'm still in awe every time I see a before and after for one of these, how dramatic the change in vessel caliber can be. This just goes over the equipment that we use. Sometimes we use these balloon catheters, and it just allows us to inflate a small balloon inside the blood vessel so that we can inject the glue-like material without it being pushed forward in an uncontrolled way by the pulsations of her arterial systolic blood pressure. We can go to the next slide. This is also a pretty dramatic one. It's a 62-year-old who was actually diagnosed with early onset Alzheimer's. They thought he had early onset cognitive decline. It was progressive, but he also had tinnitus. So as a neurologist astutely had ordered an MRI and a CTA to make sure that this wasn't anything else. And you can see on the CTA that it's very asymmetric in the left hemisphere. This is normally when they time the CTA, they time the scan for when the blood is on the artery side. Almost like an angiogram, they time the CAT scan to spin when the cardiac cycle drives that contrast into the arterial phase in the brain. While on the left side, you can see that the contrast is opacifying all these cortical veins. And those cortical veins you should not be seeing on a CTA. So we did a diagnostic angiogram. And very similar to the last one, very ugly looking blood vessels. This one is even more dramatic in terms of how significantly it distended the middle meningeal artery. You can see on the maybe the left picture, that blood vessel at the bottom that's curving kind of to the northwest corner. That blood vessel is a little bit lower to the right, a little bit lower, a little bit lower. That blood vessel right there, that blood vessel coursing down, that's the middle meningeal artery. And normally that blood vessel, again, should just be a small twig, but it's actually almost the same size as the external carotid trunk itself. So very abnormally dilated blood vessels. Everything that you're seeing up top, that's actually the Sylvian vein. So that C-shaped kind of sickle that you're seeing up top, that's this normal vein that courses in the Sylvian fissure, but about 4 times the caliber that it should normally be. So this is a very high risk lesion. It's on the left side, so he had, word finding difficulties actually, and that was directly due to this venous congestion in his language hemisphere. And you can see that this early venous drainage happens throughout the left hemisphere. It's going back into the transverse sinus, going down into the straight sinus. A very pathologic lesion. So this is something that required a multimodal treatment. This is treated both endovascularly and through surgical clipping. We actually got a pretty good result through the onyx embolization, but there's still a small trickle of contrast that was getting to the venous side early. So we knew we didn't cure it. We knew that because we didn't cure it, if we left it alone, it was just going to come back in a raging fashion. So he was taken to the OR the next day to definitively cure it. But I think the endovascular approach was helpful in this case, because if he had just taken this guy to surgery without that endovascular preoperative embolization, he would have lost liters of blood intraoperatively. These intraoperatively are extremely vascular lesions. I think the endovascular pre-op embolization really helped this guy out. But his cognitive status actually returned to normal, and he ended up becoming neurologically intact a couple weeks after this lesion was taken care of. And more variations on the same theme. We use a variety of different catheters, and we use onyx, higher concentration of onyx. It's called onyx 34. We use that when the flow of the lesion is so high that we need something to polymerize really fast. I'm gonna go to the next case here. I think this is probably the most interesting case, because I think you guys may have seen something like this throughout a neuro floor or in your care of neuro patients. This is a 49-year-old, again, completely healthy, who had over 6 weeks prior to presenting progressive myelopathy. He started to need a cane, a 49-year-old needing a cane to walk, and he was starting to lose function of his hands. And he got an MRI of his C-spine. And you can see here that there is what's called cord signal change, or T2 hyperintensity, within the spinal cord of the cervical cord. And this was actually treated as a presumed inflammatory diagnosis. This is treated by neurology initially as transverse myelitis. He got a huge plasma exchange catheter, underwent plasma exchange, got rounds of steroids initially, but didn't really improve. The steroids helped him a little bit, but didn't really improve. And if you, in retrospect, look at this MRI a little bit more carefully, kind of all throughout the surface of the cervical cord, you can see all these little dots. Those are called serpiginous flow voids. And yep, those dots kind of all along the surface of the spinal cord. And normally on this MRI, you should not be seeing any of those vessels. Those are dilated veins. Those are dilated veins on the surface of the spinal cord. And what was happening to him is he was actually having so much venous congestion as a result of an underlying fistula in the spinal cord that it was causing progressive myelopathy. So we did a diagnostic angiogram. And you can see here that picture to the right is a microcatheter injection of the ascending pharyngeal artery. So a branch off the external carotid artery was directly dumping into the veins surrounding the spinal cord. It's a very rare variation of a dural arteriovenous fistula, but when you identify it, you feel great because you know that sealing it off is going to cure this guy. So we ended up taking him the very next day, putting him to sleep under general anesthesia, and did a glue embolization. This is just pointing out the trunks, the different branches of the ascending pharyngeal artery. When we embolize through this vessel, it's a little bit tricky because some of the distal branches that you don't really hear a whole lot about actually provide blood supply to the lower cranial nerves. So you got to be very careful to make sure that your glue doesn't make it up to those branches that are supplying the lower nerves, the hypoglossal 9, 10, 11, because you can actually cause pretty significant dysphagia, dysarthria by unintentionally embolizing some of those vessels. And we got a angiographic cure, and the next picture kind of says it all. That's before and after, and that's a 6-week follow-up MRI. His cervical cord is completely normalized, and you can see that you should not be seeing those dots on the surface of the spinal cord. Those are completely gone now. Those dilated veins are all completely gone, and he actually walked into clinic completely neurologically intact. Yeah, I think that was probably. Yeah, go ahead.
Were those dots missed on the first read of the scan, or was it just because it was read differently by somebody different?
I think it was missed, to be honest with you. These are very difficult to diagnose, and they're not like, it's not like an egregious miss where like you miss a subarachnoid hemorrhage or something like that. These are very, oftentimes these will have undergone actually multiple MRIs, years of MRIs, and people can't figure out what's going on. And that's usually the patients who get ultimately referred to us for a spinal angiogram. It's almost like a diagnosis of exclusion. The diagnosis itself is extremely rare. The likelihood of him having transverse myelitis is much higher than him having a dural AV fistula in this location. But in retrospect, those vessels are abnormal. And clearly, now we know the reason why. But it's not unusual for these guys to be, or these patients to be treated like this. They get treated empirically with a presumed diagnosis of transverse myelitis, because there's no way of confirming that diagnosis aside from seeing how they respond to treatment. And I think I have like 1 or 2 more cases. This is another one, very young person, was a graduate student who had intractable tinnitus, just could not sleep at night, kept hearing his heartbeat anytime he tried to lay down. And on a CTA, again, he had this abnormal network of vessels in his transverse sigmoid sinus. So we took him for an angiogram, and he has what's called a transverse sigmoid dural arteriovenous fistula. This is a pretty classic fistula, and it basically recruits all of these normal meningeal arteries into this fistula's pouch, causes early venous drainage. And because of this abnormal arterial flow in his venous system, which is located right behind his ear, he hears his heartbeat. This is a very satisfying case where we were able to treat it entirely endovascularly. This is just showing the venous phase of the angiogram. And the thing that is notable on this is we injected the right hemisphere. So you can see the right hemisphere is lighting up, but you can see that the right hemisphere is actually draining down to the left transverse venous sinus system. And that indicates that there's so much reflux and so much backlog of blood on the right venous sinus system that the right hemisphere is not draining normally. So this is another indicator to us that this needed to be treated. And this is how ugly it was. This is an external carotid artery injection. There's a lot of stuff going on, but it essentially is just a multitude of blood vessels feeding into that fistulous pouch, draining into that transverse sinus system, and causing us symptoms. And we ended up doing an onyx embolization of this, and we were able to get it completely treated. You can see there on the next slide, that's the liquid embolic cast. It looks very extensive. This took about 5 hours to complete, but definitely worth it. He ended up getting a radiographic cure, and at follow-up, he has no recurrent symptoms. I think this second to last case, kind of variations on the same theme. This is the same guy who has a very similar guy who has a transverse sigmoid fistula, but oftentimes you're not able to get it all through a single approach. So we staged him. Initially went through the arterial side and then ended up going through the venous side to coil it. And if you skip through these, you can see how extensive some of these end products can be. You can go to I think the slide after this. Yeah, so that picture shows you how much treatment he's undergone. He's got maybe $20,000 worth of coils in there, several vials of liquid embolic, and that's what it took to finally seal this thing off. And I think this is the last case for this series. We haven't completely treated this guy yet, I don't think, but this is also kind of a way a dural AV fistula can mimic another disease process. So this is a 77-year-old who initially had a large left parotid mass, and he also concurrently had PET positive lesions in the cerebellum, and they had initially preemptively diagnosed him with metastatic disease and leptomeningeal spread. So they thought that he had a malignancy in the left parotid gland and that had spread to the surface of the cerebellum. And you can see here on the MRI, very hard to miss. He has a huge parotid mass, and you can see in the cerebellum that the surface of the cerebellum is much brighter than normal. Sometimes that's what leptomeningeal spread can look like. And when someone does have leptomeningeal disease, it's a very poor prognosis. It's 3 to 6 months at best, because it's spread all over the surface of the brain at that point. It's incurable. But at tumor board, this was presented, and one of the radiologists said, wait a minute, there's something that looks a little bit abnormal in terms of the blood vessels on the ventral surface of the brainstem. And you can see that on the front of the pons and the front of the medulla and front of the cervical cord, there's all these squiggly looking lines. Those are abnormally dilated veins. And actually, he did not have leptomeningeal disease. He just had venous congestion in the cerebellum that was radiographically mimicking leptomeningeal disease. And he actually had his parotid mass resected, and it was completely normal, or not normal, but it was not malignant. It was pleomorphic adenoma, which is a benign diagnosis. It does not associate itself with any malignancy. It certainly doesn't spread to parts of the brain. So at that point, we decided it's probably a good idea to do a diagnostic angiogram to figure out what's actually going on. So we did that, and this is actually kind of subtle, but so these are injections of the left external carotid artery. And on the left side, there's a PA view. On the right side, there's a lateral view to get you oriented. And you can see that the lines going towards midline, exactly, those kind of horizontal lines, those lines are actually what the normal caliber of the middle meningeal artery should be. So kind of as a point of reference compared to the previous cases where you saw those middle meningeals that were huge, this is kind of the normal caliber of the middle meningeal. You just barely be able to see it, but it's dumping into that midline area. That's actually the confluence of sinuses, or the torcula. And all those squiggly lines that you're seeing going in the downward, the kind of downward lateral direction, a little bit up top where you had your mouse previously, Kelly. One higher.
Right here.
Yeah, exactly. That thing that kind of looks like a mustache on both sides, those are dilated cerebellar veins. That M-shaped structure there towards the middle, that's cortical venous reflux in the cerebellum, which is terrible. If you have venous congestion in the posterior fossa, that's for sure going to lead to a bad hemorrhage. So he ended up being diagnosed with a torcular fistula, or a dural arteriovenous fistula involving the torcula of the venous sinus system. And you can see on the next slide that this torcular fistula was recruiting branches of the vertebral artery called the posterior meningeal artery. So the posterior meningeal artery supplies the dura of the posterior fossa and the occipital lobe. And this fistula system was recruiting that. You can see all those lines on the surface of the cerebellum are abnormally ectatic veins. So this is really kind of an interesting presentation of a fistula. He had undergone all these other workup thinking that he had a underlying malignancy, when in fact it was actually a vascular etiology that he had. So we're planning to embolize him. Hopefully it goes well. I think if we're able to get a cure on this guy, he's gonna do well.
Sorry, Yifei, was I pointing to the right? These ones are not supposed to be here?
Yeah, those are actually the normal vessels. Those are the posterior meningeal arteries. That M-shaped structure that you can see kind of in the middle of the screen, that
like this?
Yeah, exactly. That, and then leading laterally, those are abnormal cerebellar veins that you should not be seeing them that prominently, and you certainly shouldn't be seeing them in the arterial phase. And that's it. That's all I had. I think some of these still end up looking like Jackson Pollocks, but I think if you understand the underlying anatomy, I think you can start making some sense of things. And they are very gratifying patients to take care of. They're very thankful. They led normal lives, normal healthy lives prior to this diagnosis, and being able to get them back to that is a great privilege.
Wow, this is like probably one of the best interesting presentations I've heard recently. So this is really awesome. Thank you for this. Even that has to be so amazing, just like, thinking you have, early onset dementia or, a brain tumor, and then all of a sudden, you're able to offer this treatment. I can see
it's
why you get excited about this.
Yeah, it's a very emotional thing for patients to, have a complete turn of expectations. They have reasonable hope, and a lot of these diagnoses are misdiagnosed as degenerative, progressive problems that don't have cures. And when you're able to offer someone a treatment like this, they're very excited, as you can imagine.
That's interesting. Can you explain the onyx a little more? I guess I always thought it was just kind of like a glue, and you went to one spot and kind of like, just
So onyx,
we added a little glue, but you said that it actually can travel.
So onyx, we use two different types of liquid embolic agents. One is called MBCA, which is just called M-butyl cyanoacrylate. It's honestly just super glue. It's actually super glue that we inject through the catheter, and it seals up blood vessels. And you have to rapidly get your catheter out, otherwise the catheter gets glued into the blood vessel that you're trying to embolize. That we use only in one of the cases here. Onyx is a very unique material. It almost looks like it looks like latex paint, and it is more cohesive than adhesive, meaning that it clings onto itself more than it clings onto vessels. So what that gives you the ability to do is you can push this column of onyx or liquid embolic, and it basically gradually makes its way through the blood vessels, seals blood vessels from within, seals blood vessels on the back end, and it's highly visible. It's highly radio dense, so you can see it as you're doing it. And the good part about it is, number one, you're less likely to glue in your catheter. And number two, it flows in a more controlled way. So you can you have the ability to start, stop, and then restart, which is a very important thing to do. It's a very important quality to have when you're working with a liquid embolic.
How often do catheters get glued into like a vessel with the other treatment, the MD, BA, or whatever?
I've been very lucky, and I personally haven't had to explain to a patient that we glued a catheter in the last couple of years. We actually
if you glue it, it just stays there?
Yeah, so if it glues it, you actually have to just basically cut the catheter at the groin, and it's permanently connected at some point.
Oh my goodness, that's crazy.
Yeah, so we typically try to avoid that. They have these microcatheters that actually have a detachable tip, so that if you were to get that glue to reflux back on your microcatheter, you can still pull the system out, and it's intentionally designed to detach at the tip, like a kind of like a gecko lizard tail, and it prevents you from having to leave the whole microcatheter in.
Wow. What if you happen to glue like the wrong vessel? Is there a way to get the glue out?
No, it's very unforgiving. It's very unforgiving. So that's where the morbidity of the procedure comes, is if you don't fully understand the anatomy, or if you're too greedy with the liquid embolic, it can go places that you do not want it to go. And the problem with the circulation of the brain that I think everyone underestimates is there's all these potential anastomotic channels between the external carotid and the internal carotid, the vertebral artery and the external carotid. And as you can imagine, the worst case scenario is you're thinking you're embolizing something in the external carotid, and this stuff ends up traveling up to the vertebral circulation, and you start causing brain stem strokes with this glue, because it'll seal off vessels. It seals off vessels very well, but if you're sealing off the wrong ones, then that's very problematic.
That's good. How do you guys train to use the product? Do they give you like, I guess, demo vessels, or?
Yeah, we have demos, and it's a lot of reading about it, but you don't really learn how to use it until you've pushed it a couple times. Initially, you're very timid about pushing it, and that's okay. It's good to take your time doing it, but it's definitely not it's not something that you can just describe to someone and them knowing how to do it. It takes a few times.
You as like a fellow, do they give you the opportunity to do this on patients?
Yeah. Cool. The training here is very good. I'm very lucky, and it's very unique because like I know fellows at other programs throughout the country, and they're graduating having never pushed this stuff, and then they're suddenly expected, going out into practice to be able to do these types of procedures. It's kind of scary.
Yeah, that's weird.
How long would something like would all this stay together? Like, would there be a potential where you would have to redo these treatments at a certain point?
So that's a very good question. So I typically, if you've gotten an angiographic cure, meaning that you don't see the vein light up early at all, the likelihood of it recurring, very low, less than 1 to 2%. But if you leave even a small sliver of fistula left, it's 100% going to come back. So if you're going to try to treat it, you definitely want a good plan to make sure that that you're able to seal it completely. We typically do a 6-month follow-up angiogram on these. And if there's any question about residual venous drainage, we're pretty aggressive about retreating it. But thankfully, I haven't had. I can't remember the last time we did one, and there was a big recurrence.
That's good, especially because I feel like we get a lot of people with the same kind of things that come back a lot. So
yeah,
I'm glad this is one thing that they don't have to worry about maybe as much.
Yeah, no, and that all just comes from like if you fully understand the anatomy and you know exactly where you need to seal, then that gives the patient the best chance at getting a cure. But oftentimes it just looks like this. It's very hard to decipher.
Yeah. Mm-hmm.
You may not know this, but how often are patients with dementia getting brain scan? Is that fairly typical, just to rule out anything else, or
usually, I think Alzheimer's, as far as I understand it, that's kind of a diagnosis of exclusion. Typically, they undergo like some sort of intracranial imaging to then finally get that diagnosis. And usually, like the scan has to be normal, or like there has to be like atrophy.
Yeah,
it has to be like atrophy, but no, no. It's basically just to rule out tumors, rule out things like this, and if they don't have it, then they get stuck with that diagnosis.
Does anybody else have any other questions? Well, Yifei, surprisingly, you took the entire hour, so Thank you so much. So
this painting, by the way,
yeah, we'll let you go now, but it was awesome. Thank you.
This painting was the most expensive painting in the world. I think in maybe 10 years ago, it sold for like $120 million.
Really?
Yeah, and this guy literally just splashed paint on this huge canvas, on like a swivel chair in his office.
Oh my gosh.
Kelly, we're doing the wrong stuff.
We can redo it.
Yeah.
I still don't know what it means. I'm not like a big fan of abstract expressionism. I think it's just cool that this is kind of what fistulas look like.
Yeah. I think it was a good analogy.
Yeah.
All right, thanks, guys.
Yeah, thank you.
Thank you.
Appreciate it.
Yeah, no problem.
Thank you.
Have a good evening.
You too. Thank you.
Bye.
Okay, well, I'll stop recording now.